Yeah, you got it.
Good morning here actually in Colorado, but for many of you, it's good afternoon, and perhaps for some of you, it's good evening. My name is Pam McClain, and I will be your moderator for the next 60 minutes. On behalf of the American Academy of Periodontology, as well as the Osteology Foundation, I would like to welcome you to the first of a series of 3 virtual forums for the new periodontist and resident. And these are all under the umbrella of managing complications related to regenerative therapy around teeth and implants. How this started was following the success of the Regeneration Symposium at the 2021 AAP annual meeting in Miami. We were really excited to expand the knowledge and take a more in-depth look at the programs that were presented during that session. Hopefully, and I'm really hoping you all had a chance to review Dr. Hom-Lay Wang's presentation, the course that he presented in Miami titled Managing Hard and Soft Tissue Complications, Managing Hard Tissue Complications Around Teeth, both in furcation and as well as intrabony defects. Our format today is a little bit different. This is not your traditional speaker with slides. This is more of a, I'd say, live virtual podcast. We've done a lot of different things in the past, and we find that when we give programs at our meetings, there's very little time for discussion afterwards, and people really miss out on that Q&A session. So we hope to have a very lively discussion. We've received quite a few questions from the participants already. And you will also have the ability to ask questions through the Q&A portal that is on your Zoom towards the bottom of your screen. I'll do my best to answer as many, get those questions asked, and Dr. Wang will do his best to answer those questions as well. Participants will receive a unit of CE credit, and those CE certificates will be issued to your email within 5 to 7 days. So our speaker, or our guest, I should say, Dr. Hom-Lay Wang, is the professor and director of graduate periodontics at the University of Michigan. He received his DDS from Taipei in Taiwan, and his MSD and DDS from Case Western Reserve in Cleveland, Ohio. He also has a PhD from Hiroshima University in Japan. Now, Dr. Wang has co-edited 2 textbooks. He has published more than 50 chapters in books and has invited reviews and has more than 720 scientific articles. He remains active in numerous organizations, as well as serving as editor and reviewer of many reputable professional journals that we all read. He is the recipient of some of the highest awards our profession can give, including the prestigious Master Clinician Award from the AAP. And I certainly could go on, but I think we should get on with today's topic. And welcome, Hom-Lay. Thank you so much for your presentation in Miami, and then for taking the time today to have some discussion about this important topic. I guess to start things off, I'd really like to find out how you ended up in perio, and specifically how your passion was driven towards regeneration.
Thanks, Pam, and good morning and good evening and good afternoon for many of you from a different part of the world. Dr. McClain asked a very nice question about how do I get involved in perio. I guess in a life, it's always kind of unique. It just happened to be because I'm always passionate about doing the surgery. And when I was young at that time, I was following an oral surgeon, and he is doing the oral surgery procedure. So I get very in love with all this bloody procedures. Nonetheless, when I come to the USA and I was thinking about which program should I apply, and the oral surgeon deal with a lot of big procedures, and I thought, it's not aesthetic enough, it's not dedicated enough, and I always believe I have a dedicated hand, so I say maybe I go with a little bit more dedicated surgical field, such as periodontist, and that's why I applied the perio program, and actually most of you probably don't believe it. I just applied one school and one program, and because I don't have money. So I pick up the program, which is not a big city, so it's cheaper, so I can live. And also it's a shortest duration, so I can finish the program with whatever financial resource I had. And was lucky, and I end up become a periodontist, and then I become a faculty. And so that's how I started with a perio. And then you get excited about all the research affiliated with a perio, in particular on regeneration. And that's where I started my research.
Excellent. Well, having reviewed your course again, and I enjoyed it in Miami, but it was actually fun to go back and listen to it again. I think it's obvious to us that the best way to manage complications is to never have them in the first place. And obviously that's easier said than done. But with guided tissue regeneration, it seems that one of the most common complications has to deal with membrane exposure. Could you provide some guidelines as to, first of all, how to prevent membrane exposure? And then once you do have this, when is it a concern? How do you manage it? And in fact, when do you make a decision to remove the membrane, depending on the type of barrier you're using?
I think this is a great question. So I'm going to illustrate on the case I show during the presentation, and then take you through how I think the wound healing process will be. So let me share the screen with all of you at this moment. I hope you get a chance to read this case. So let me do it very quick. Okay. This is the case referred to me. And for implant placement, sorry about my name there, but it's okay. It's almost like a class 3 furcation, and was referred to me and want to take the tooth out and place the implant. And many of you probably think about implant will be a more longevity. And I know implant does come with some of the problem too, such as periimplantitis. So in this case, I probably around the area would start, it's about probing depths 8, 8, and 8, which is surrounding this area. And the reason I decided to try to do regeneration on this particular tooth is because in this patient, the whole mouth just have this perio defect. So if it's only one defect, I think it's pretty much you can target. And the reason I show this case is if you look here carefully, and you can see the etiological factors, which is the plaque and calculus. So if you can remove them, then you will have a great chance to regenerate. But in here, I wanted to share with you, when you're looking in this case, it will explain to you why membrane get exposed. So if you're looking into after your cleaning, you can see the distance is wide. So now if you know the distance is wide, if you're gonna place the bone graft, such as in this case, to support and to make a space, now you have to think about once your bone graft is go in, you actually blocks the blood supply. And even though you do the papilla preservation incision, or you preserve the papilla, you do the incision, trying to maintain the soft tissue. But what happened is, after this, you will end up placing your membrane for the GTR, guided tissue regeneration. It's an occlusive membranes. So you place your membrane there, and to block the cells you don't want, which we all know is the epithelial cells, the connective tissue fibroblast. That's a cell you don't want. So you put it there, but you have to think about everything has two sides. One is good, one is bad. You can block the cells, but you also blocks the blood supply. And what is most important is a blood supply to support your flap. And that will keep your flap closure. But because you have incision on top, so your two incision lines is going to come in contact together, but you have a bone graft and membrane to block your blood supply. So in order for the blood supply to come up, it's very difficult. So most likely you're going to have a wound opening on the top line because that's the biology. And what happened is, this one the patient come back at 2 weeks, you're going to see this. And this in particular, there are two different membranes, which Dr. McClain asked very nicely. You can do collagen membrane. You can do we call non-resorbable membrane, like a PTFE membranes. But if you ask yourself, if I place collagen membrane versus the PTFE membrane, which one is going to get more perforation or the more membrane exposure? For sure, it's more rich membrane. It's a non-resorbable membranes. So the research actually show you if you put a PTFE membrane there, the chance for them to get exposed is about 70 to 75%. So you're going to get exposure. Now, if you know when you get exposure, it's going to compromise your outcome. So your result is not going to be predictable. So how you're going to manage this when the patient has exposure at 2 weeks? And this is the question Dr. McClain also asked. When do you remove the implant? How do you deal with it? You know, I always said one thing. If you don't know how to deal with it, what are the correct answer to tell your patient? Come back next week. So you can go home and think about it, how to deal with it. Am I correct? But during that week, what do? You're going to give patient antibiotics. You're going to give a patient a good oral hygiene and antimicrobial mouth rinse agent. So for you to think about it. And you know, in this case, you won't be able to close it because with the biology I just mentioned to you. So what I did is I always put a cold pack to protect the wound. So there's no food trap in that area. Then I give antibiotics. Then I give the antimicrobial mouth rinse agent. And I see patient next week and next week after. And I will make sure the hygiene was there. And you can see the hygiene is supposed to be there. Then slowly, the bone will growing back and soft tissue will close the area. So you can see in 9 months, we have some regeneration, not a bad regeneration coming up. So the management of this, you're going to give the antibiotics and to control this infection. So you learn this. Now you're looking at 18 months, you're looking at 30 months. We pretty much has a regeneration almost 80, 90%. But again, this is how you manage the exposure. So in a GTR, it's very important for you to understand the membrane exposure may not be detrimental. It may be reduce your result, but you still can get some result if you know how to manage it. So that's a very important. So when do I remove the membranes? I usually said, if I have a 4 to 6 weeks, I still have exudate. I still have the breathing and I cannot control the field. And with all this, the pus and exudate, then I will probably remove it at that time because that's a time. I want to keep my membrane intact and being in place for at least 6 weeks. That's usually where the cell migration will be accomplished. So if you look at here, then let me look at it 5 years later. You can see I maintain the result in the 5 years from baseline to the 16 months. So to me, I think I can keep the tooth for five years with the outcome, which I'm very pleased. It's a class 3, but I can get a regeneration the way I feel I did something good for the patient. Now, most likely, I want to share with you one thing for you to really think about it, membrane exposure. It all defined into 2 sides. One is a collagen membrane. One is EPTFE membranes. So when you read the literatures, you have to differentiate. Don't put them together. They are totally different materials. So in the EPTFE membrane, the pain, the appearance, and the membrane exposure will be the #1 thing. So you will see it, which will cause your exposure, and you have a swelling, you have a slough of your flap. So that's something you have to know. But collagen membrane, because they can resorb and degrade it, so it's much tolerant to the exposure. So if you're going to have exposure and the chance for potential exposure, you're going to go with more resorbable membrane instead of rigid, non-resorbable membranes. So that will be my long answer to your short questions.
Well, I actually have a follow-up question on that. So you mentioned antibiotics. Is it if membrane's exposed and the tissue is tolerating that exposure, would you still use antibiotics?
Usually, it's a good question. When you do the GTR, you can ask yourself, most likely you don't need to give antibiotics if you don't have exposure. But for the legal purpose, and also for the management of a potential infection, such as a bone graft, and you usually like to prescribe antibiotics to cover it. And unfortunately, in the US, in the legal manners, the lawyer always asks this question, did you prescribe antibiotics? Why not? And in order for you to continue to justify, find all the literature to support not using antibiotics, sometimes it becomes more difficult. And if I place a bone graft, if I get a membrane exposure, I usually will prescribe antibiotics. However, if I twist that question a little bit, if I do a membrane with biological agent, then I got membrane or flap exposure, most likely I probably won't give antibiotics because it's a biological agent. To me, it's not a graft material. It's going to stay there for a while. And that way I will probably go with without antibiotics.
And then follow up also to that, then if you prescribe antibiotics, what type of antibiotics do you use? Let's say you have a non-resorbable barrier there's purulence present. What antibiotic would you choose?
So
barring any allergies.
If you're looking into oral thermolyte extraction and oral surgeon deal with oral cavity infection, the number one antibiotics they prescribe usually is amoxicillin or augmentin 100 milligram. And I think there's a shift toward to more augmentin these days because they can anti-against the enzymatic from the resistance of your amoxicillin. So you can either do amoxicillin 500 milligram TID for 7 to 10 days, or you can do augmentin 100 milligram BID for 7 to 10 days. That's my first defense. If a patient is allergic to the amoxicillin, then I will give a Z-Pack, usually Zithromax, and I usually give 250 milligram, 6 tablets. 2 tablets, which is 500 milligram for loading dose, then 1 a day for the remaining 4 days. So totally 5 days regimen.
And I know that one of the questions, and then maybe this is a good time to ask that, has to do with your, both your pre and post-operative regimens. So do you use antibiotics prophylactically when you do these surgeries?
Actually, I don't. I don't think the prophylactic antibiotics is needed in this type of the procedures. However, if your patient hygiene is not good, it's not a candidate for doing this type of procedures. I always said hygiene was the key. 50% of your success is coming from your patient. Like a preacher always said, you as good as a periodontist or surgeon, you can only achieve 50%. The remaining is from your patient. So if you cannot train your patient to have a good oral hygiene, then you shouldn't do the procedures. So if you have a good oral hygiene, then I don't think you need antibiotics, unless if you really want to push the patient is compromised, such as the patient is a smokers, such as the patient has a diabetics, or the patient, that's a potential more prone to have a flap exposure or potential infection, then you will cover the area with the antibiotics. And most likely, I don't.
Thank you. And Hom-Lay, your antibiotic, somebody just asked about the antibiotic regimen. You had recommended either amoxicillin 500 TID or augmentin. What was that again?
BID.
BID and 875s or 500. What did you say?
No, the augmentin, usually you can go with the 250 milligram.
250, okay.
Yeah. Some people using 100 milligram is also fine. A lot of the surgeons using 100 milligram, that one augmentin, but it depends.
Okay, thank you. Thank you. Well, moving on to a little different topic. You mentioned the importance of keratinized tissue and the thickness of tissue. Could you discuss that as it relates to barrier and GTR procedures? And there's more specific questions regarding the use of like dermis as a barrier to also increase that thickness. Maybe you could address that.
Okay, that's an excellent question. So let me share with the one I always tell my residents. I always said, if you're going to start into doing the GTR procedure, and you want to have the procedure starting with a good ideal candidates. And to me, the ideal candidates or the defects is the patient who has a very nice systemic health, good oral hygiene, good compliance. And I prefer as a non-smoker for my first case. And I want to have a wound stability. That means I want to stabilize a wound. Then this is a very important. I think you have to understand the way adequate tissue thickness is more than 1 millimeter. Sometimes the people will trick you and put a 0.5 millimeter. you want to be a thickness because the study actually showed that when you have more than 1 millimeter, you have a less likely to get a flap exposure or the membrane exposure. So that's actually a little bit different. Then you like to see the area with keratinized tissue by more than 2 millimeter. And you want to see a defect which has the attachment loss more than 4 millimeter. Usually refers to your defect or infra-bony defect is more than 3 millimeter. Anything shallower than that, you can do osteosurgery. It's actually more predictable. And you don't want to try to do the case on a class 3 furcation sometimes. But in this case, the ideal candidate is a class 2 furcation defect. And the defect depth is more than 3 less than equal to 7 millimeter. So that's, to me, it's good. So this is the way I look at how to avoid the GTR complication. So do I matter with the tissue thickness or not? Yes. If I have less than 1 millimeter tissue thickness, some people from Italy group, they're actually using the connective tissue graft as the grafting materials. And this is trying to answer your question about using dermal matrix. So let me show you this case, and I want to make sure that you understand this case a little bit. Then I can actually answer the dermis very quick. So we'll show you one case. Let me show you a case very quick, so you know. We actually using the collagen membrane, not a collagen membrane, CT graft as your barrier membranes. And we can increase the thickness, and we can also do the regeneration. So let's show you this case. So in this situation, you got a furcation, you got a class 2 furcation defect here. And you can place the bone graft, and you can take a CT graft, and you can close the flap. And you can see they actually end up very nice regeneration. So can you use in the CT graft? Yes. As your regenerative material, yes. But you need to have enough bone graft material because the soft tissue is going to invade your graft material. Now, you say, can I use in dermal matrix? My answer is yes and no. Yes means what? You can get a primary closure. Not let that dermis exposed. Then you can increase the thickness. But the dermis has one challenge is they usually easy to get exposed. Once they get exposed, they usually does not behave nicely. So to answer your question in the way I describe the defect, for infra-bony defect, interproximal area, for sure, I will not use in dermis. I will use in the CT graft if I have to use it. But I will use them for my class 2 furcation because that's in the buccal side or lingual side, I can close it much easy. So in the proximal area, if I have to think about the soft tissue as my barrier membranes, I will go with the CT graft in the interproximal area. So that's a little bit different. So artificial material, always the furcation area. Okay.
Thank you.
I hope that answers your question.
I do too. It answered, of course, I think it was very clear. And, you know, as we talk about these barriers, there's obviously a lot of barriers to choose from. When we first started down this path, we really just had one, that was the EPTFE. And there are still some non-resorbable barriers available, but one of the questions that came up is, you know, if you use a non-resorbable barrier, which type do you use, since the traditional EPTFE membrane is no longer available? And how do you select? How do you choose? Is there a specific go-to barrier for you? You do a lot of research, so obviously you're doing research with different barriers. But if now you're in your private practice and a patient comes in, do you have a categories on how to choose? And is there a non-resorbable barrier such as EPTFE, or there are alternatives that you use, and what would that be?
Pam, it's a very, very good question. You know, we grew up in the period of the Gore-Tex membrane, which is the expanded PTFE membranes. And we all love that because they are expanded, which has a pore size allow you to attach and stabilize. But now that company went off the production line. However, I do hear about they're going to come back. Hopefully they will come back. Other than that, I think we have a dense PTFE membranes.
Mhm.
And the dense PTFE membranes, it's no pore size, and it's actually totally occlusive. And one of the precaution the company will tell you when you do a GBR, they always tell you that PTFE membrane cannot touch the tooth. And you have to be away from the tooth by at least 1 to 2 millimeters. So to me, there's really no non-resorbable membrane for GTR. To me, that I don't think I will use that at all. Because at this moment, if I use the dense PTFE membrane, if I touch a tooth, I'm more prone for exposure. I'm going to have a nightmare. I have to deal with it. If I have to deal with the exposure, I would rather deal with resorbable membranes, which is the collagen membrane, or even the, we call it bio-exclude umbilical membranes, which is the umbilical makes the membranes. You can let expose, we call open wound concept, and you can allow them to deal with it. Although more research is still needed, but I will go with that route. And certainly I talked about using CT graft and even using the we call it aeroderm. And to me, they got enough material out there for you to choose. You don't have to go back with the PTFE membranes. And the other things people usually forget, we used to have a guido membranes. They come with a suture, and that's also a great membranes to use on treatment because they come with a suture. They have a pore size. So if you can control that, they're also resorbable. And that's a micro membranes, so you can use in that too, if you really want it.
They're just now very limited in the sizes and shapes in that type of barrier. Thank you. A number of questions have arisen on the use of biologic agents, and when to use them, which ones to use. Do you add it to your graft? We've got PDGF, we've got ED, EMD, PRF. How, and as our research expands and we have more knowledge, how might this affect them? Do you use any of these biologic agents, and do you incorporate them in with your bone grafts? How do you use them?
Okay, it's actually a great question. I know all these wonderful biologic agents going to enhance our ability to treat and to regenerate. But I'm going to share with you where I think you should use it. Remember, the research always try to tell you what future comes. And most likely, we learned in the past, we do surgery from the crestal down to the apical. And I believe one day, most of your generation, young people generation, you're going to do surgery from the apical up, not the crestal down. Because we used to trend always cutting the crestal and go down. But when you cut in the crestal, what you did is you break the papilla. And then you put your membrane below the papilla area for regeneration. And that's usually, it's the most detrimental to the regeneration. You want to protect that blood supply, and you want to protect that interproximal tissue. So in order for you to do that, I remember PD Miller talked to me at one time. And PD was a great soft tissue guy and guru. He said, I always do a regeneration without even raise the flag. And when he talked to me that, I say, how do you clean it? He said, I do a tunnel and I really inside and clean it to make sure everything's clean. But I want to protect that papilla. Then it goes to tell you why it's important to keep that papilla intact. So you can see the recent articles since the 2017 from Cotellini Group and Aslan, they are doing the entire papilla preservation for regeneration. So you're starting to see people think the same way. If I have a defect like this by 12 millimeters, very deep, in order for you to protect this defect, they try not to even open the papilla in the proximal area, and just from the side area and get access to clean and keep this papilla intact. So it's kind of tunnel procedure with the papilla without interfere right here. And then you can actually clean and you can put a bone graft with or without biologic agent. And a lot of times when you do an entire papilla preservation regeneration, you can use a biological agent. You can do the Emdogain, you can do PDGF, you can do PRF. I think that's the area you can use. It actually works very well. That's why in all the Italian group by Pini Prados, the minimally invasive procedure, what do they try to do? Get rid of your barrier membrane, go into a biological agent. So if you're going to do a biological agent, the key is keep your papilla intact, protect that blood supply, then you will get a result. So in this sense, you can see they did a lot of this regeneration by doing the lateral vertical release incision and keep the papilla on the regenerative area. Then put a bone graft with the EMD or without EMD. As long as you have a bone graft there, it should be okay. Because what this group did very interesting is in the 2020 study, and they did the same things, and they put it with group, with EMD and without EMD. And what do they find out? EMD, additional of regenerative biomaterials, such as EMD plus bovine bone, does not improve the clinical outcomes. So as long as you maintain the papilla, sometimes you don't need the biological agent. But again, for me, if you ask me about what's my choice of the biological agent in combination with my bone graft materials, so this will be my choice. If I'm going to do EMD, which is endogen, I will mix with allograft. Human allograft, that's how I always mixed. That's in the US, everybody using that approach. Now, if I'm doing the PDGF, in Europe, you can mix with bovine bone, which is like a bio-os, which is fine. That's the way they're always showing the wonderful result. So PDGF with bio-os. And then the PRF, you can mix with both because that becomes a sticky bone. So to me, either one, to make it easy for you to manipulate. So that's the way I will use for the biological agent.
And Hom-Lay, in these cases, when you do those, especially when you're doing these papillary preservation techniques, based on what I'm hearing you say is you wouldn't need a membrane, or you don't use a membrane in these since you've got your intact papillae. Is that correct?
That's correct. However, if you want to increase a little bit of tissue thickness, the material I will use is actually a free connective tissue graft. So that's some things I will use because that will increase the thickness. And also I like to use in the CT graft is because they can increase the thickness and they can protect my bone graft in situ. So that's the way I do if I really want to push it.
Well, this case also might lead into another question, and that is in terms of the effects of bone grafts, because as you said, here in the United States, there's a lot of allografts used, and in Europe, very few because of some of their legalities. But what, based on your interpretation and knowledge of the literature, are the effects of the different bone grafts, allograft, autograft, xenograft, alloplast, and how would they impact the combination with guided tissue regeneration in furcations and intrabony defects?
So let's first differentiate between the infrabony defect and furcation defect. I always place the bone graft in the furcation management. So that's a given, okay? So for me, if I have a furcation defect, I always combine with a bone graft, with the membranes, if I really want to treat it. Now for infrabony defect, then that's a different story. If I have the natural bony wall around it, like a two wall or three wall narrow defect, I don't need have the bone graft. I can put a membrane, I get the same result. So we did a lot of study, and then the data shows that if you have three wall defect, the membrane with or without bone graft gets you the same result. So you don't need a bone graft in the infrabony defect. However, when there's no space-making capacity, the bone graft is always essential. Your bone graft is your space-making capacity. Now, you're going to ask me which one I prefer to use the bone graft. I like to see a bone graft will be slowly kind of we call resolved by the body and replaced with a new bone. So I like to see the bone graft turn over quick. In that case, usually it's allograft. If I really use it, I think allograft will give me that turnover. However, for the people from Europe or from some other country like China or Japan, the allograft is not feasible. You have to use a xenograft. Then I will mix with, we call it a PDGF if it's allowed. That usually show you a better combination, or even EMD that will give you better outcomes. That's the way I do.
And Hom-Lay, with the allograft, obviously, if you use a mineralized graft, radiographically, you have instant improvement. Do you favor a mineralized or demineralized allograft in your cases?
This has become a little bit of debate issues. And if I can go back with the history a little bit and let people understand a little bit. The first bone graft available is actually mineralized bone graft. And it's Marshall Uris, it's 1965 in the lab in UCSF. He took this bone graft and somehow it demineralized and see the protein expression. Today we call bone morphogenetic proteins. So in the demineralized, they actually has the bone morphogenetic protein expression. So it's more osteoinductive capacity. But all the mineralized, it's osteoconductive. So they can hold the space better for many of you trying to maintain the space. And therefore, if you ask me in GBR, what would be my choice of a bone graft? I would say the mineralized bone graft. However, for perio, I want the regeneration. I want the osteoinductive. I want the bone morphogenetic proteins. So I like to use the demineralized bone if I use in the perio defect, because that will be there. Now, the argument I can tell you, the research didn't show you that. If I use in the mineralized bone graft, when I place in the site, they have to go through the demineralized process. So it's going to take longer. That's why mineralized bone grafts stay there longer, because it's going to go through one more step in order to demineralize and to express the protein, hopefully form bone. So in a perio defect, you want an instant to help out. That's why you use the demineralized bone. That's the way I look at in the science and literature.
That's a great answer. I appreciate that. And along the lines of again, managing these defects, and I think very little time is spent on preparing the wound, the defect itself. And anybody who's done this type of treatment knows that the majority of the time you spend in surgery is probably debriding and cleaning the tooth itself, because without a well-prepared root surface, we're not going to get the kind of response we want. Along those lines is the use of any type of root conditioning agents and what effects they have, and whether or not you use a root conditioning agent, and which one might that be?
It's a very good question. I know I talk about this in my lecture, so I'm going to try to find that slide to help many of you to understand a little bit of literatures. So you know, when do you use the conditioning agent? When do you say no? And let me get that slide and show you the literature. Basically, most of the literature will show you that lunar conditioning agent does not enhance regeneration outcomes. However, if you want to use the lunar conditioning agent to enhance the fiber attachment, which is the primary purpose for lunar conditioning agent, it's disinfect the root surface and give you more attachment on the fibers attachment. So you have a two purpose. One is disinfect the area. Second is give you what we call the dental tubule opening and increase the surface contact area for better regeneration outcomes. Okay, so let me get that outcome if I can find it. Sometimes when you have so many slides, it's difficult. So
while you're looking for that, somebody asked which type of collagen membrane, and I don't know if you mentioned any specific types of collagen membranes you use. I think you talked about the biologic barrier, I think the placental amniotic barrier, but are there other collagen barriers that you use and that you would prefer based on their cross links or stiffness, et cetera, for guided tissue regeneration, not for GBR?
For the guided tissue regeneration, all you need is the membrane. It only lasts for 4 to 6 weeks. You don't want them too long. There's no reason for them to stay there long enough. And that will actually create more exposure for you. So anything lasts from 4 to 8 weeks, that should be perfect for you. So that's what I look at. So you don't need it to use a longer lasting one. And some things like a regular, like a BioUS, the BioGuide or or bioman or oral man, that should be fine. And even the bio-exclude membrane, that should be also okay. I don't have a problem on that. I can see if I can find it somehow. It's just difficult for me to get the citric acid or tetracycline. Basically, the studies show that most of studies show you the citric acid, tetracycline, luteal conditioning agent does not enhance regeneration outcome. Lisa Heinz Mayfield also show you that using the EDTA does not. However, I think Pam, you know that you published a paper on the IJPRD shows that the luteal conditioning actually enhance the regenerative outcomes. So you are the group showing that it's going to help. So to me, I think it does no harm. If you want to use it, I'm not against it. But the most study will show you it didn't have any benefit at this moment in the research wise. Okay, so that's the one I know.
Thank you. Do you do any root conditioning when you manage your cases?
Personally, I find the slide I can upload and I will tell you I don't, but I think one thing you can do, if you really wanted to do today, for me, I will actually, I like to try lasers. So to me, I think the laser, it's maybe a fun tool to use because I want to disinfect the area. So I may like to use lasers, and I know this is the area I'm very excited about doing more research on it. And this is the study actually show you that on the GTR without luteal conditioning. And most of the studies show no, and Dr. McClain's article shows yes. So you can see here, and even Lisa Heinz Mayfield show you no difference on EDTA. So that's the way I look at it.
Very good. As you talk about, helping and enhancing, you mentioned this PASS principle. Could you elaborate on that? Maybe you've got, I don't know, maybe you could pull that up even in your presentation.
Okay. The PASS principle is the one, I was actually put it in that way. I was sitting in there and eating my lunch and then figured out this together with my sandwich bone augmentation. And it's a funny story, but anyway, I was asking myself, if I want to have area to get a regeneration in a predictable manner, what kind of condition should I have? Then I asked myself, if I want to have a wound to heal without disturb or without any kind of outside insult, that has to be primary wound closures. And I also know that all the undifferentiated mesenchymal cell, in order for them to come to the wound site, they need to have a blood supply, so-called angiogenesis. So you need to have a blood supply. Without blood supply, they die, they slough. And the joke I often said to my students, no space, no gain. So you have to create space there if you want to regenerate some things. And this is some things I can actually help many of young people today. A lot of times when you do the implants, and prosthodontics will say, I don't want a full trap. So they will put a restoration, cover the contact point. But what's the problem? Because once you occupy the contact point, the body will never allow the soft tissue to go there. So you actually create recession. You promote the recession. You didn't help. You worry about full trap, and actually you create more harm. You should always make the contour the way the patient can clean. Then the bone is there. They will bring the soft tissue come back. So that's called a space. Then if you have a tooth mobility, if a tooth, you put it in regeneration, it's moving the tooth plus mobility. There's no chance for getting the regeneration. So wound stability becomes important. Then I will sit there and try to figure out what makes sense, what not makes sense. So I came up with a PASS principle. That means if you want to do GTR, if you don't know PASS, you will never pass the GTR. So that's the way I look at it. So that's a PASS principle is you have to know the concept. Otherwise, your GTR will never succeed. You will never pass the GTR. So that's the way you can remember it.
So it's good. We hate to fail. We'd much rather pass. So when you look at the wound stability, I mean, both you're looking at the tooth itself. Is there a degree of mobility that you'll say either I'm not going to treat this or this tooth needs to be splinted?
Usually, I like to do a regeneration when the mobility is less than 1, according to Miller's 1952 mobility classification. If a mobility is more than 2, I always do occlusal adjustment and bring them together with adjacent tooth. I don't want to do the GTR on the mobile tooth. It's the same things I always said to the people. You never build up your own house in a floating sand, because the floating sand is not strong enough to hold your house. It's going to disappear.
Absolutely. In treating furcation defects, let's kind of go back to furcations. Is there one critical factor? And I'm trying to incorporate as many questions that have come in, but furcations obviously are, in my mind, one of the most challenging lesions to treat for many standpoints. Is there one critical factor that you would say, yes, I would treat this, or no, I wouldn't? And you know, I mean, we could look at a specific case and maybe you could share how you make that decision on whether to treat or whether not to. And then along those lines, what are your expectations if you have challenging furcations?
So let me share the screen, show you a couple of furcation I treated. And, you know, I've been doing this since 1989. And I don't want to tell you how old I am, but actually I'm not young, but put it in that way. So let's look at on the case I treated my first GTR 1989. You know, and if you can look into that, a class 2 furcation. And I put a membrane there and I got regeneration. That's the reentry. Actually, I clean up, this is totally regeneration. So you can see it's actually very good. Then you can see in a time when I was trying to learn all this GTR concept, I also intended to let the membrane expose, because Lou in the 1992 articles in the journal Perio, he said a very important, in order to block the cell's migration, you have to put a membrane above the CEJ, otherwise you got concave, so the cell can go into that area, so you're not totally occlusive. So I even let the membrane expose, so I get a complete occlusive and I get regeneration. So that's the way I look at it at that time. Now, today, we don't do this, because when the membrane get exposed, they resolve very quick within the 2 to 4 weeks. So they don't have the things you wanted to do. And the way I look at it, see, that's the way. So now this slide show you what's the number one things I look at. I look at the interproximal bone here. I look at the proximal bone there. So if the interproximal bone is higher than my furcation, I will try the regeneration. Because my bone is high, I will have a chance. But if I see this bone is here, then forget it. I don't have a bone support, then there's no chance to get a reverse architecture to get regeneration. So that's going to be exercise purpose. You're not going to get a result predictable. So in the proximal bone, should be higher than the furcation you're trying to regenerate is the one I look at. And that's what I say the number one things. Then I looking into all other things we talk about, tissue thickness, keratinized tissue, oral hygiene, mobility, and stability, primary wound closure. So that's the way I look at it.
I totally, we haven't discussed this ahead of time, but I totally agree with you, Hom-Lay, because sometimes you open those up and the furcation, the depth of the furcation is important as well. But let's say you have a 4 millimeter horizontal probing depth. However, that interproximal bone's laying apical to the roof of the furcation. The outcome is, I mean, you can still achieve some success, but I would not anticipate complete coverage or complete fill of the furcation. And it sounds like you agree with that as well.
Yeah, I do. That's a great insight.
Yeah, and there's so many aspects of furcations that are challenging from the internal anatomy, which oftentimes, you know, we have so little access to that it creates further challenges. But from your experience, when you look at periodontal defects and when we're talking about regeneration, from kind of the top, the most predictable defect to achieve success to the least predictable, what would you say are those?
3-wall infrabony defect is probably the number one most predictable. Then 2-wall narrow, better than a 2-wall wide. And then your class 2 furcation, it's easy. You never do a regeneration on class 1. It's not. And upper, the mesial and parietal root and distal and parietal furcation, it's always difficult because the excess is a challenge. So that's the area I always say you need to think about twice. And class 3, it's not as easy as you think you can do it. Now, the other things I want to mention to many of you, if you want to do a regeneration, I always try to tell people, you have to know the etiology. In this case, people want to do a regeneration. I will tell you, forget it. You will never get it because you put your crown margin right in the furcation area. Then you're going to have a 3 millimeter biologic width. And this is actually build up your so-called supracrestal fiber attachment, so-called biologic width. And then you can put a bone graft here, whatever, it will never regenerate. Unless you remake a crown and you create a biologic width for the patient, then you can regenerate. No matter how much bone, you have to understand the etiology because this is the biological width and you have to control it. And I see this all the time. And the students will come and tell me saying, Dr. Wang, I did a bone graft membrane, but it didn't work. And I would say, did you ever look into a crown margin? Did you violate the biological width? So I think that's also very important concept. When you select a case, you need to know what case works. That's what exactly you just mentioned.
Right. Case selection is critical. And you mentioned, class 2 furcations, predictable, as long as you have certain parameters, that interproximal bone and access to the intrafurcal area. I mentioned earlier, there's oftentimes we spend so much time just showing surgical cases and what we used and what we did, but we don't talk much about the postoperative care. And at least in our practice, that's been a really critical part of achieving success. Can you just quickly give us an idea of what is your postoperative regimen from, whether or not we talked about antibiotics already, what do you tell them to do it, home care wise? What about diet, professional visits, et cetera? What is the typical follow-up for patients?
It's a good question. For any patient I treat during the surgery and then before the surgery, I will tell the patient after the surgery, 3 to 4 days, you're going to have some swollen, some discomfort in that period of time. So the patient won't get upset. And so they expect some of this kind that will happen. And I always tell you the practice management 101, call your patient the next day. Just ask how they are doing. And then I usually see patient in 2 weeks. Why do I see patient in 2 weeks? Because if I see patient in 1 week, they always complain. They hate that first week. At 2 weeks, they're coming back and they just want to take that stitch out because that stitch bothers them a lot. So once you take a stitch out, they always hug you, say, thank you. It feels much better. So I like that way. So that's the way I do. Now, what do? Beside the antibiotics, I don't like to give it chlorhexidine. And some of you will think about I'm crazy. I give the warm salt water. Why? Because I think warm salt water is more kind of mild and also it works very well and promote the cells. Chlorhexidine, it's wonderful. They can disinfect the area, but they also kill the cell I need, especially if I do a collagen membrane. Because the collagen is a sponge. When you have the chlorhexidine, they soak with collagen and they will slowly release and they will kill the cell you need for that wound site. And I want a primary closure. So I often give the warm salt water for the first 2 weeks. Then I switch to chlorhexidine. I don't have a problem after that because I get my primary closure. Now, one thing I change is every 2 weeks, I will using the toothpaste with my Profi cup and polish the area. So toothpaste, I don't use any Profi paste, but the toothpaste, and I clean the area. So I see patient at 2 weeks and then 4 weeks. And if a patient is fine, then I will see patient at 2 months and 3 months and every 3 months for the SPT. And also check the mobility, make sure there's no movement.
Very good. I guess, we don't have a whole lot of time left, but what do you see? And you mentioned a little bit about lasers and whatnot, but what do you see? Is there anything new on the horizon that will facilitate and improve outcomes with more complex defects? Because, the trend for a number of years was, hey, listen, implants are easy and predictable. Let's take teeth out and put in implants. But obviously we know there are problems with implants and managing implant defects is much more difficult than tooth. So what do you see coming out help us maintain and preserve the natural dentition?
I'm going to tell you, if you ask your mom at one time, what is the best gift they can give to you? It's your own teeth, okay? And if you take your gift from your mom out, then you lose it, because that will never come back. That's a gift. I still always believe your own teeth is much better than the implant. And that's a 101 you have to know. So now, what's a new technology? What is new horizon to improve the ability to save? We have we can use a microscope to clean the area, and we can do a more conservative approach. We can do the scalp foam, which is the digital fabricated bone graft material to fit in the defect, so we can have a much better fit. And we can do from apical up or tunnel approach to do a regeneration. So all these things will make us much better clinician. I think the number one challenge for many of us today is we cannot clean the defect nicely. If you can get rid of the things gum didn't like, then, or teeth didn't like, you have a regeneration. Because once you remove the calculus plaque, it's supposed to be normal. And the reason you didn't remove it, how many times when you remove the tooth due to a perio reason, you see a residual calculus? You do. That's because you didn't spend time to really clean it. Before 90s, we all saved the tooth by doing the regeneration. Today, every one of you want to take a tooth out, put the implant, then creates another problems called peri-implantitis. I'm dealing with peri-implantitis every day, and I don't have a solution. I can tell you that. And that's the dead end. Although I publish a lot of papers on peri-implantitis management, it's something. It's a struggle, but hopefully one day we can figure out a solution. So keep the tooth. It's still the best gift from your mom.
I know there are a lot of other questions that people have, and I just I think we've got about 2 minutes. Hom-Lay, to kind of finalize things in your your vision for the last 30 years, and I'm right there with you. So I think we're both still very young. What do you think is the most important? What's the biggest thing that has evolved in periodontal regeneration? And of course, with implants, to me, it's even more important now that we look back at regeneration to preserve teeth because of complications with implants. How do you see what is involved? What's the most challenging and important thing for us to take home from this?
I think that regeneration is here to stay with all the biological agent or the new things coming out with a capacity. We are actually looking for using the current to stimulate bone formation. And we're showing some wonderful data out there. So it's there. We have a microscope access to looking into the area. We can clean the area much easier than what we do. I will tell you, spend time, learn it, be patient. I think the young people want to be an instant success, like instant grant. Life is not that way. It takes time to nurture, to practice, and to do a good job. It does not come in 30 minutes. I used to clean a section of a scaling root planing by at least 1 hour. Asking the young people today, when you clean half a mouth, how quickly you finish? Probably 5 minutes. And how can you clean up the teeth the way they're supposed to, free of calculus or plaque? So I think that's a challenge to many of you. If you say that the new technology can speed up you clean the teeth by 30 seconds, then I think that's a solution. But that's a tough.
I agree. I totally agree. And I hate to say this, but our time has completely flown by. I didn't expect it to go so quickly. I would really like to thank you, Hom-Lay, so much for your excellent presentation in Miami, but also the time you spent with us today and sharing your knowledge and all those important critical tips. It's so valuable. I think it was very insightful and timely. And I would again like to thank the AAP collaboration with the Osteology Foundation for bringing this important webinar to you. I'd want to make sure that you all know that there are 2 more webinars like this coming up, one on May 11th with Gustavo Villa Ortiz and on September 21st with Martina Stefanini. Check your junk mail or spam mail if you don't get the announcement about these webinars. And I would really encourage you to take 5 minutes to complete the survey. This today was actually a unique and very different program that the AAP has put on, and we want your feedback. We'd like to know if these kinds of formats are important for you. So always visit the perio.org, and on behalf of the Academy and the Osteology Foundation, I just want to thank you for your time, and we'll look forward to seeing you again, either virtually or face-to-face. Thank you, Hom-Lay.
Thanks, Dr. McClain. Thank you for you all. Be safe and be well. Thank you.
Thank you. Stay well, everyone.